Hi everyone, I'm Dr. Yang from Joint Shantou International Eye Center. Our topic for today is papilledema. Before we start, I would like to thank Dr. Lee for the pictures. What's papilledema? Papilledema is swelling of the optic nerve head, secondary to raised intracranial pressure. It's nearly always bilateral, although it may be asymmetric. In patients with papilledema, we should suspect an intracranial mass. All other causes of this edema in the absence of raised intracranial pressure are referred to as disc swelling and are usually associated with persistent visual impairment. So, how do we differentiate papilledema from other conditions such as papillitis, pseudopapillitis, and AION? I hope you can meet this objective at the end of this section. If we want to understand the pathogenesis of papilledema, we first need to know the circulations of cerebrospinal fluid, CSF. CSF is formed by the choroid plexus in the ventricles of the brain. It leaves the lateral ventricles to enter the third ventricle through the foramen of Monro. From the third ventricle, it flows through the Servian aqueduct to the fourth ventricle. From there, CSF passes through the foramina of Luschka and Magendyle to enter the subarachnoid space, some flowing down to the spinal cord and the rest bathing the cerebral hemispheres. Absorption is into the cerebral venous drainage system. It's through the arachnoid valve. The causes of raised intracranial pressure include the following: idiopathic intracranial hypertension, pseudotumor cerebri, obstruction of the ventricle system by congenital or acquired lesions, space-occupying intracranial lesions, including hemorrhage, impairment of CSF absorption via arachnoid villi, which may be damaged by meningitis, subarachnoid hemorrhage, or cerebral trauma, cerebral venous sinus thrombosis, diffuse cerebral edema from blood head trauma, severe systemic hypertension, hypersecretion of the CSF by a choroid plexus tumor, which is very rare. All of the above conditions will cause an increase in intracranial pressure. Next, let's go through the symptoms of raised intracranial pressure. Headaches may start any time of the day, but characteristically occur early in the morning and may wake the patient from sleep. They tend to get progressively worse, and patients usually present to the hospital within 6 weeks. The headaches may be generalized or localized and may intensify with head movement, bending, or coughing. The patient may develop nausea and vomiting, often projectile, which may partially relieve the headache. Vomiting may occur as an isolated feature or may precede the onset of headaches by months, particularly in the patient with tumors in the fourth ventricle. Deterioration of conscious state may be slight, with drowsiness and somnolence. Dramatic deterioration of consciousness is indicative of brainstem distortion with tentorial or tonsillar herniation and requires prompt attention. Visual symptoms include transient obscurations, horizontal diplopia, and visual failure. Transient obscuration lasting a few seconds are frequent in patients with papilledema. Horizontal diplopia due to the sixth nerve palsy caused by stretching of one or both 6 nerves over the petrous tip. This is therefore a false localized site. Visual failure develops late with secondary optic atrophy due to long-standing papilledema. Papilledema involves through different stages. In the early stage, There are no visual symptoms, and visual acuity is normal. On exam, we can find mild dyshyperemia with preservation of the optic cup, indistinct peripapillary edema nerve striations and disc margins. In established or acute stage, transient visual obscurations lasting a few seconds may occur in one or both eyes, often on standing or bending forwards. Visual acuity is reduced. We will find severe dyshyperemia, moderate disc elevation with indistinct margins and absence of the physiological cup. There is also venous engorgement, peripapillary flame hemorrhages, and cottonwood spots. As the swelling increases, the optic nerve head appears enlarged. High exudates may radiate from the center of the fovea. The blind spot is enlarged. In the chronic stage, visual acuity and the visual fields begin to constrict, associated with severe disc elevation without cotton spots and hemorrhages. Optociliary shunts and drusen-like crystal-like deposits may be present on the disc surface. Lastly, in the atrophic stage, also called secondary optic atrophy, visual acuity is severely impaired. The optic discs are a dirty gray color, slightly elevated, with few blood vessels and indistinct margins. This table shows the main differentiating features of papilledema, papillitis, optic vasculitis, AION, and pseudopapillitis. Papilledema is secondary to increased intracranial pressure with CNS symptoms, for instance headaches, nausea, and vomiting. Even deterioration of consciousness and cranial CT shows enlarged optic nerve diameter. The prognosis depends on the primary disease. Papillitis is an inflammatory disease causing reduced visual acuity. Cranial CT shows demyelination of the optic nerve. This condition usually has a good prognosis but may recur. Optic vasculitis is considered to be an autoimmune disease, usually unilateral, with mild or severe visual impairment and high exudates. The outcome is good if treated properly. AION is caused by ischemia, with sudden painless visual loss. Visual field shows the characteristic inferior orthodinal defect, and the prognosis is not good. Pseudopapillitis is a congenital condition. The appearance looks a bit like papillitis, but all other examinations are normal. These are my references. Thank you. See you next time.